Awesome. So this neurology, let me minimize this a little bit so that we can see the whole screen. Okay, you can see, right? Okay.
Yes, yes,
So it's gonna be like 3 hours until 1 o'clock.
yes,
All right.
yes. Is that
Okay.
okay with you?
Yeah, that's fine. Okay, so this neurology, so neurology, like you cannot do the exam without knowing neurology. They ask a lot of questions on it, and it's kind of broad. You have to understand the nervous system itself and all the sensory systems mostly. They link it to the eye, the ear, the dermatomes, and all over muscles, So now, this is the first page from the book, and from here, the most important thing I'll focus on is this image here. Let me put on this. Okay, draw. All right. So here you can see, right? You can see my marking.
Yes.
Awesome. All right. So here, we want like the division of the brain from when the baby was being formed, right? And so it's divided into three first, the forebrain, the midbrain, and then the hindbrain. And they want you to understand and remember the derivatives of each of the parts. So, for example, the forebrain is divided into the telencephalon, diencephalon. The midbrain remains the same, the mesencephalon, and the hindbrain also divided into the metencephalon and then the myelencephalon. And and so very high yield, very high yield. Okay, so if I tell you very high yield, it's either we are not supposed to disclose anything from the exam, right? Yeah, but if I tell you it's
Mhm.
very high yield, you have to, if I stress on it, you have to know that it is very high yield. And um so what is going to happen here is that as all these parts divide, you want to be able to remember which part is gives rise to what, right? Because in the exam, what they might do is that they will give you maybe a symptom, right? And then you know that, okay, this is what a cerebral stroke, or they'll give you a symptom, and you know that this symptom is coming from the midbrain, or it's coming from the hindbrain. But they'll just go ahead and bring you back to embryology and ask you
Embryology.
the part of the brain that this symptom is coming from developed from which part, like which of the following. So like maybe is it from the telencephalon? Does it belong to diencephalon, mesencephalon, or myelencephalon? The way I would want to remember this is I just recite it till die, right? That's how I recite till die, then mess, met, mile. Mile always comes last, right? Because why? Because of the Y there, right? Y is always at the last part of the alphabetical order, right? So that is how. So just recite it till die, mess, met, mile. If you recite that over and again, it's gonna stay till die, mess, met, mile. And so for all this, we also know that they also give rise to different parts of the brain, as we can see from this side, right? So the two cerebral hemispheres are from the telencephalon, right? Are from the telencephalon. And the diencephalon gives rise to the thalamus. The thalamus are just on the side of on the side of this, but they are the lower part of it, right? So it's like you have the thalamus, and then the cerebral hemispheres are sitting on it. They are sitting around it, and then the thalamus is also resting near the midbrain. So the midbrain remains the same here. The mesencephalon gives rise to the midbrain, right? And then we also have the pons, the medulla, and then the cerebellum from the hindbrain. Very important. They love this part. Very important. because it can get students confused. So the pons and then the cerebellum, you have to know that it's from the metencephalon. Very, very important. If I wouldn't know anything at all, I will know this one because everybody knows this. This is obvious, but the pons and then the cerebellum are what confuses people, right? So basically, and then we have to know that the ventricles are within the first two, the lateral ventricles, one here, right? And then we also have the third ventricle inside here, right? And then they join. You have to know how the CSF also flows because they love to ask the questions on that. So if we talk about the CSF flow, are you okay if I ask you some questions so that it's more interactive?
Yeah,
Okay.
not the CSF flow.
Yeah. Are you able to remember the flow of CSF, where it is made first and where it goes next, and then where it goes next to exit in the around the spinal cord?
No.
Okay. So in the brain, in the cerebrum, there are two, right? We have the
Lateral ventricles.
good. So we have this like left and right cerebral hemispheres, right? Then into each of them, that's where we have the ventricle, which is a cavity, right? Now, this cavity is lined by some specialized epithelial cells called the choroid plexus. Choroid plexus. So those choroid plexus are what makes the CSF, right? The choroid plexus, they also have villi on them that helps to move the CSF around. So the choroid plexus lines this, which is very high yield, very, very high yield. You have to know that choroid plexus lines this. It also has some specialized blood vessels over there in there, so that for those blood vessels, if a child is born premature and there's excess pressure on the child did not receive vitamin K and all that, and they start having signs of increased intracranial pressure, it is these vessels around the choroid plexus that got broken, right? Those vessels got torn. We might see that later. So now, if we make the CSF here and inside here, the ventricles, they move through here. They move here, and this, if there's a cavity here, that would be the foramen of Monro, right? Foramen of Monro. And then it comes into the third ventricle. So this is the first ventricle, maybe two. Then the third one is this one. So the third one will be inside here. They are just in the middle of the thalamus. So we have one thalami here, another thalami on this side, and they are passing through it. So this will be the third ventricle in the diencephalon. Right, and then from there they move down from the third ventricle, and they move down over here. Right. So if we want to, what's the name of this? What's the name of this channel that the CSF exits when it's leaving here?
Into the spinal cord.
No, we are still at the brain level. We are now coming to we are still at the third ventricle. The spinal cord will be down here. The spinal cord will be down here, but here from the lateral ventricle. So let me see if I'll see an image of the brain here for you. Give me a minute. Okay, let's use this image. All right, you see this, right?
Yeah, the homunculus.
Say that again.
No, I said the homunculus, the one with the leg and the face and all that.
Yeah, yeah, this one. How about this one? This one. Yeah. So with this one, you'll notice that we have this will be a cerebral hemisphere here, this another cerebral hemisphere, right? And then from that, the fluid goes here, It flows this way and goes here. But we haven't reached the spinal cord level yet. We are still, so this one hemisphere, one is on the other side also. Then now we are on this side here, right? Before we come to our brain stem, this is the midbrain, right? At the midbrain level, before we come to the brain stem, which is the pons and then the medulla, before the spinal cord will come later.
Okay.
It makes sense, right?
Yeah.
All right. So let's just go back there. And then we see that we're talking about. And if I'm moving too fast, it's your class, so let me know, okay? And
it's okay.
Yeah, if there's something you want me to re-emphasize on, hey, how do I remember this long term and all that, just let me know. Okay. All right. So this is where we were. This where we were. I can clean it and do it again. So that
No, it's okay. We're just going to talk about where the CSF flows out for around from between the midbrain and the
from the third ventricle. So from the
yes,
lateral ventricles, it comes from the foramen
goes through the foramen of Monroe, gets into the third ventricle.
Correct.
So the question was that where does it go, exit from?
Yeah. What is the exit of the third ventricle?
Yes.
Yeah, that's the question. So the exit of the third ventricle is the aqueduct of Sylvius, right? Yeah, the aqueduct of Sylvius, or some will call it the Sylvian aqueduct. Sylvian, I think SIL, Sylvian. So the aqueduct of Sylvian, then adduct of Sylvius, right? So that would be the exit of the third ventricle. Then we'll now come to the brainstem area right here. And when we get to the brainstem area, we'll have the fourth ventricle over there, which looks like a rhomboid structure around here. And then this rhomboid structure has over here has an exit here and has another exit here. Then when the CSF exits here, it now goes around the brain because the brain is being covered by 3 layers, right? So this will be connected to the subarachnoid space, right? So the fourth ventricle will exit through here, and these are lateral ventricles, right? So we call them the foramen of Luschka. Luschka, L for lateral, L for Luschka, right? Then from here it goes around the brain by to be in the subarachnoid space. That makes sense, right?
Yeah.
Good.
So this is not in the FA. So where do you think I should revise this?
So with this, honestly, it's not in the first aid. Like they don't spell it. Not everything is in the first aid. Not everything, but they test you on it.
That's the problem.
They want you to know. So most of the things, if you don't get someone to tell you about it, or you don't also meet it in the U world, then maybe you have to meet it online or medical school textbook. Right. That is why it favors the students who are right in school, who are in school. Yeah. So so can we proceed from here? So now,
yes,
when it goes around the subarachnoid space, you should also know that the spinal cord also has subarachnoid space around it, just like the brain. Whatever covering the brain has, the spinal cord has the same. So the fluid flows around the subarachnoid space, around the brain, and also in the around the spinal cord as well. Yeah. So the brain and the spinal cord, they are just floating in that fluid that we just made from here. All right. That makes sense, right? You also have to know the layers, the covering of the brain from the pia mater, which is the closest, right? Then which one will be the next one?
The pia mater or the dura mater? The pia mater, then you have the arachnoid matter.
Arachnoid. Then
Then you have the bridging veins in there. And then you have that comes to dura mater that is under the skull.
the dura. Good.
Under the bone.
Correct. The bone. Yeah. So the dura will be the strongest, right?
Yes, the dura mater. So from the bone to the dura mater, then to the arachnoid mater, then the pia mater, they get to the brain. But between the dura mater and the arachnoid mater, that's where you have the bridging veins that can tear sometimes.
Okay. And then if there's rupture of the bridging veins, what do we get? If there's rupture of the
you get the subdural hematoma.
Subdural hematoma. Subdural hematoma. Awesome. Awesome. And if somebody what vessels get torn for someone to have subarachnoid hemorrhage?
There's a bridging subarachnoid hemorrhage. Yeah, it's the bridging veins. The bridging veins around the I read that this morning.
But you just said that subdural is bridging veins, right?
Yeah, subdural hematoma is, you said subarachnoid hemorrhage. Oh, okay, subarachnoid. So usually there is due to the rupture of some circular aneurysm, some berry aneurysm or circular aneurysm.
Yeah.
Or sometimes you have them in the AV malformation.
Correct.
And that's how you have subarachnoid hemorrhage.
Correct. And those ones, you want to know that they are usually part of the circle of Willis. Those AVMs.
Okay.
They are usually part of it. Yeah. Where the circle of Willis, like you have different veins joining, the joints of the vessels, they are the weakermost parts of them. So like if you have the anterior communicating artery joining with the maybe the posterior communicating or something.
Anterior cerebellar and the anterior communicating.
Yeah. So anywhere
that junction. So they said they don't have media, and that's why they tear easily.
Correct. Yeah. So did you have any question from the page that we just left?
Well, apart from medical school, but I think that's new information that I wouldn't have studied at all. So
correct.
I'll just go back and do that CSF one more time.
Yeah.
Look at that. I've seen it. There's some things you look at and you think they're basic, and then you just
yeah, very important.
Ignore or just don't put more effort. But I'm going to go back and study that.
Okay.
The CSF flow.
All right. So with step one, you want to take every information very serious. With step one, every information is very, very serious. So neural tube defect is very, very important. I know you will know that. And then you have to remember that anytime there is a neural tube defect, alpha fetoprotein goes up, and this enzyme also acetylcholinesterase will also go up. And then we have different types. The only time they'll go up is when there is an opening here. So we have the spinal bifida, we have the occulta, and we also have the cystica. The cystica has two types, the meningocele and then the myelomeningocele. So very important that we take note of that. And usually the baby will present, because it's a spinal cord problem, if it's this one, the baby will present with a limb weakness, right? That will tell you that the spinal cord itself is being affected. But here you will notice that the cord itself is not affected, but it's only the bone that has a problem, right? So that wouldn't really be a problem. The only thing that you will see will be this tuft, and the question will tell you that there's a tuft like this. Either there's a tuft or there'll be a depression. If this hair tuft is not there, there'll be a depression over there. That tells you that it is the spinal bifida, but it's not visible. That is why it is an occulta, right? It's an occult one.
So they go in and repair the bone, or they just leave it like that?
This one, they don't usually do anything about it, since it's not, they grow normal, and because the child is also a baby, the bones are still forming, so it can close. Yeah. The only time they'll do something is if there is a neurologic deficit. Yeah. And here also very important to know this. extremely important topic. So with this, we have we have Chiari 1 and then a Chiari 2. These are the posterior fossa problems. What is happening is that usually you want the foramen magnum, right? If you remember the at the base of the skull, we have some holes, right? Or canals or channels that the nerves have to pass through. So all the cranial nerves, they have to come out from all those holes and at the base of the skull to supply whatever they're going to. And then the spinal cord also comes out from the skull, but that has the biggest canal, which is here at the base of the skull. That's the foramen magnum. If you remember that, right?
Yes.
The foramen magnum. So this foramen magnum, it can become extremely large to the sense that to the point where the brain stem wants to move out of it, herniate out of it, right? Then there are some people who may also have like the cerebellar vermis. The vermis is also absent, right? And because the vermis is absent, the lower part of the brain becomes so small, and even if the foramen magnum is normal, the brain still wants to herniate through it. So they have the Chiari 1 and Chiari 2. So with Chiari 1, it's only, so they said ectopia of the cerebellar tonsil, right? So it's only one structure, Chiari 1 for one structure, right? Only one structure that is missing. But if you look at Chiari 2, there are two structures that are missing, the vermis and then the tonsil, right? Both of them. So here is only tonsil. If you want to take the I as one, it's just only tonsil. Then here we have vermis and then the tonsil. The vermis is like here. If you take the cerebellum, this is the cerebellum here, right? The vermis will be like the middle part of it. If we can look at another image, you see that the vermis will be the middlemost part of it, and then the tonsils are down here below here. So what you want to know that they love to ask is the associations. Very important, the associations here. UWorld or the NBME will ask you, okay, they'll let you know that the patient has Chiari 1, then they'll ask you what is it associated with, or something you have to diagnose and say that the patient has Chiari 1 from your imaging. But you want to know that Chiari 1 is associated with syringomyelia, which is this over here. There's a syrinx, which is like a canal, a big hole inside the spinal cord. It is because the tonsil is not there, so it puts a lot of pressure on the spinal cord, and so the CSF pressure creates a big hole at the center of the spinal cord, and that hole is just the central canal, which is a normal thing, but just at this time is bigger. It makes sense, right?
Okay.
Yeah, it's the central canal of the spinal cord, but because the tonsil is not there, there's more pressure on the CSF, and then it creates that big hole it expands the canal. And then when it's expanding the canal, what you have to know is that there are it can put pressure at the centermost part of the spinal cord. And then later, when we look at the signs and symptoms of this, you will notice that the pain fibers, the fibers that carry pain, there's spinothalamic fibers that carry the pain, right? They cross at the center, and when they are crossing, because this canal is too big, so this is the spinal cord, for example, I'm drawing, then the canal is here so big. And then if we divide the spinal cord, this is just a rough drawing, right? You find that the pain, temperature, and cold fibers are around here. And before they go, if they pick anything from this side, they pick it here and then they cross. They cross around here before they go up to the thalamus, right? So if this hole becomes so big, right, it will impinge on this crossing fibers of the pain fibers. So the person is going to have problem perceiving pain, and because it's happening here at the cervical area, they'll only have bilateral loss of pain and temperature on the arm, only the arms, and it's always bilateral. It makes sense, right? So
Yes.
once you see
if
that,
you look down, if you go further down,
Mhm.
you see what you're trying to say.
Let's see. I don't know which page we are going to meet it on, but I'm just
No,
prepping.
it's the same page.
Oh, it's the same
Answering
page.
it's
Okay.
just further down to push the page up.
Awesome. Good. Awesome. Good. So yeah. So let's finish with this one and come there. Okay.
Okay.
All right. Okay. So the associations are very important. You want to remember it. Very, very important. So carry one, syringomyelia. I remember it by just picturing this. It's a hole, and this whole thing is writing one, right? It's like it takes a shape of one inside the spinal cord. So carry one, syringomyelia. Now carry two, yes. Carry two is two things that are missing, and this is associated with the spinal bifida, which is the myelomeningocele. Right. So that's what you also want to remember. Carry two is myelomeningocele, and carry one is associated with syringomyelia. Okay. Awesome. So now let's go to the syringomyelia. Dandy Walker, they ask it sometimes too. So it's also associated with non-communicating hydrocephalus and spinal bifida, but this has to do with agenesis or total absence of the cerebellar vermis. Total absence of the vermis. All right. Okay. Now, syringomyelia. Syringomyelia. This topic is a topic that usually, like, it's kind of rare, and a lot of books don't talk about it, but it's important to know it. So just as I was explaining, you have the syrinx, which is like a larger central canal over here, and that central large hole is putting pressure on the whole spinal cord at that level, at the cervical level. So so if you look at here, if you see, if this is our spinal thalamic, right? Spinal thalamic, because the thalamus is recepts all the sensory information that is purely sensory. Thalamus is purely sensory. Maybe like 95% sensory information goes to the thalamus. So from the spinal thalamic, if you have pain and temperature, right? Pain, temperature, and you can also find some crude touch over here. So mainly is the pain. So the pain fibers, they move across before they go up, right? So the person is going to have, since this happened at the cervical area, the person is going to have loss of pain and temperature on this side, just like we see in this image, the blue side over here. So they'll describe the question like that for you, okay? To describe the question like that for you. And once you see anybody who has loss of pain and temperature in bilateral arms and across the chest, it is going to be syringomyelia.
Okay.
Yeah. Okay. All right. And we know that it is associated with which type of Chiari?
Chiari 1.
Chiari 1. All right. All right, let's move to the next high yield topic. So neuro is kind of just, it's high yield. It's difficult to jump any topic, but if there's anything that you feel like you're more comfortable with it, we can just move on. Okay.
Okay.
Yeah, if you feel like there's anything,
so it's just that you can mention it, very important, then we can just
correct. Correct.
know that I need to focus on that.
All right. So Astrocytes are very important. You have to know that they give all the nutrition to the other part of the brain. These are all supporting cells, right? They can also call them the sustentacular cells. They just support the other structures of the brain. So they provide nutrition. They provide support. So if you see a fuel, right? And then they also support. They also form part of the blood-brain barrier, and they also form repair. So if the brain cells break down, it's the astrocytes that will try to form them. And then you have most important thing that you have to know that it is GFAP positive. This is the neuromarker for it. So
Okay.
they do the immunohistochemistry, they'll see GFAP positive, and you know that it's an astrocyte. And then this astrocyte can also form some tumors. Some tumors are also derived from this astrocyte. We'll see them later on. Now, microglial cells, these are the macrophages in the CNS. So if there is any debris that needs to be eaten up or something, it is the microglial cells that will do that. And they are also they are gotten primarily from where we derive the macrophages but they migrate into the brain to form that function of like macrophages. And then they can also fume to form these multinucleated giant cells. And what you want to know here is that in someone who has HIV, right? Someone who has HIV, the HIV cells in the brain, they go to attack these microglial cells, because just in the blood, right? If someone has HIV, the HIV goes to destroy the macrophages. It's the same in the brain. And then the person can have like HIV dementia, right? Someone has HIV and start having, over a long time, they start having dementia. They can have HIV dementia because the HIV, the virus is attacking the microglial cells. Very important that you know that. They bring you to that level, cellular level, for you to understand. So that is one thing that we want to know. HIV dementia. Okay, let me write it. HIV dementia, and also HIV encephalitis. Also, this is implicated. Very important. Okay, now let's go to the next one, the ependymal cells. These ependymal cells, we have talked about it partially in the when we're doing the CSF production. So the ependymal cells, they are this. We said there was some cells that line their, if you remember, we said they line the CS.
The choroid plexus?
Exactly. They form, so these ependymal cells are what forms the choroid plexus. Does it make sense?
Okay.
Yeah, they form because the choroid plexus, the plexus is a group of things, right? The ependymal cells are the main epithelial cells, and they are simple columnar glial. So you don't have to know that they are simple columnar glial cells, but just have to know that they are ependymal cells, and they line the ventricles to form, and then they form the choroid plexus. Yeah, they form the cilia also. So that is it over there. Very important. And you know something? So somebody has excess CSF production, or the person is not producing, but it's not being drained out, and then it just remains in the brain, and they develop hydrocephalus, right? And then you want to treat the person, and we are giving them the medical treatment, acetazolamide, right? And they want you to know where that drug is going to work. It's going to act on these ependymal cells. Okay. It's going to act on these ependymal cells. But if they want to take you more into molecular level, then they want to ask you about what enzyme is making the CSF specifically, right? Do you have an idea what enzyme that is? It's called the carbonic anhydrase.
Okay.
Carbonic anhydrase. It's very high yield, and you meet them several times. Anytime, this is in the kidney, and it's also in the brain. Acetazolamide can be used as a diuretic, right? So just as it's making us make a lot of urine and we pee the urine out, it's also acting on the brain to also stop the CSF production. I mean, to reduce it, carbonic anhydrase. All right. Okay, so here is the myelin, right? The myelin, the covering of the nerves, so that they are able to like they have some insulation, and also helps the movement of the nerve impulse. So there are some diseases that are associated with it, right? This myelin, they are just like fatty tissues. That's how I see them. They are just like fatty tissues that are surrounding it, the nerves. So there are some diseases that are associated with it. What we have to know here is that the oligodendrocytes are the cells, right, or the supporting cells in the brain that make the myelin sheath of the nerves in the brain, right? So if we take the if we take the axons of the neurons that make up the brain, right? If we take the axons of the cranial nerve 1 and 2, yeah, very important, you know that only cranial nerve 1 and 2 are part of the CNS, right? All other cranial nerves are peripheral nerves, and they are considered peripheral nerves. So in the brain, you will notice that we have the oligodendrocyte, but when we come to the peripheral nerves, all your the motor nerves, the sensory nerves that are coming from the periphery, and also those that includes the cranial nerve 3 up to 12, they are all considered as peripheral nerves, and the Schwann cells are what makes their myelin covering. This yellow thing that is covering it is the Schwann cells. So Schwann cells are for peripheral nervous system, and then the oligodendrocytes are for the central nervous system. Why do we say this? Because there are some diseases that are only associated with the peripheral nerves, and some diseases are associated with only the central nervous system. So that if somebody is having, say, a disease like multiple sclerosis, right, you don't want to say that it is due to Schwann cells, because
it's oligodendrocytes.
It's gonna be oligodendrocytes. If somebody is having GBS, Guillain-Barré, it's gonna be due to Schwann cells. So you don't mix them up. They ask these questions. They want you to know that Schwann cells are for the peripheral system, oligodendrocytes are for the central nervous system. And also remember, cranial nerve 1 and 2 are for which of the systems?
They're part of the central nervous system.
Central nervous system. They're part of the central nervous system. So that also confuses some students sometimes. Okay. All right. We will not go into this today. Electrophysiology will take us the whole day. Okay, this is also important that you look at it. The chromatolysis, you want to know the color and then this of the cytoplasm when there is injury, like when the injury occurs now, and then if the injury has taken some time, like what happens, you want to know the cells that would regenerate it, right? As we said the astrocytes help in the repair, but then when the cells break down, when the nerves break down, there'll be some debris, right? Just like a wound. Anytime that we have injury, there are some debris. So it is the microglial cells that will now eat up the debris, right? You have it's also important that you look at that also. They love to ask questions on it as well.
So this is just like inflammation.
Yes, just
in
like
the brain.
exactly, just like inflammation in the brain. Yeah. but they want you to know like the color changes that goes on inside the cytoplasm of the nerves, right? So that if the injury just happened, you might not see a lot of changes. But then if the cytoplasm turns pink, then you know that maybe there are, or if you find these Nicel bodies, then it also tells you a different thing, right?
The age of the inflammation,
Yes.
the age of the injury.
Yes, and also whether it can be reversible or irreversible. Yeah.
Okay.
Mhm.
I'll check that one out today.
Yes, yes, you should check that. Now, this page here is it looks like it's not high yield, but it's high yield. What they want you to know is each of these neurotransmitters, where it is produced, which specific location in the brain is it produced, right? But how do you remember all these things? Now, if you know where it is produced, you can get some questions correct, because what is going to happen is that you know that, let's say, acetylcholine is associated with a certain disease, right? Let's say it's associated with Alzheimer's disease. So if they give you a patient that has Alzheimer's dementia, they want to ask you that this disease is affecting which part of the brain, right? Or they'll ask you, okay, this disease, which neurotransmitter is being implicated in it? Is it dopamine? Is it GABA? It's for all of like they ask for all of them. So it was difficult for me to remember all these neurotransmitters and where they are produced. So I came up with a mnemonic, right? And I'm going to share that with you. So this mnemonic is you have to repeat it several times, okay, to know it. But when you know it, I recite my mnemonics to remember that. If you know it, you go into the exam, you will spend less than a minute to get your answer correct and to save you time. So it's CNS, and I'll show you what that means. CNS, my low rough, this P. Does it make sense? So CNS. So CNS is just from the brain, right? So this C is for acetylcholine, right? I use this for acetylcholine because it has C in it, acetylcholine. N is for norepinephrine. So C, N, S, right? So S is for serotonin. Now, which specific location in the brain are they made? Mile. So this is for the basal nuclear of Maynard. That's why I'm making mile, right? And also the norepinephrine low, right? Mile low. So this low is for the locus coeruleus. And the serotonin is made in the Ralph nucleus. So if you remember the CNS milo-Ralph, if you don't remember, you can also make it ANS. If that works for you. A for acetylcholine, right? So ANS milo-Ralph. Right. Can you recite it for me?
What about the other two?
Which one? The GABA? So
The dopamine and GABA.
this one, I did not include them in the mnemonic because I can promise you that the one they love to ask the most are these three. If they will ask something that is rare, it's gonna be GABA, which is the nucleus accumbens, and A for A is
limbic system.
That again?
It's a part of the limbic system.
Yes. And so if you know these three, you can always eliminate the rest, right? So if it's not this, it's not this, not this, you will find your answer. But mostly these are the three that they ask. So ANS milo-Ralph. ANS. I'll write it down and try to repeat them. ANS. And then when you start doing questions on neuro, you appreciate what I'm trying to tell you.
And maybe I should start. Maybe I don't know. I think there's some UWorld that is subject oriented, right?
Yes. If you world it's like it's subject oriented, you can do only neuro questions. Yeah, you can do only neuro questions on that. Yeah. Meninges, we know meninges, right? There's not much to talk about on the meninges. But if you are okay with that, right? The meninges.
Yeah.
Yeah, we know the meninges already. All right. Let me move to the next. This is very important that let me just talk about quickly. The chemoreceptor trigger zone, very important, where there's a vomiting center. And usually they want to ask you, like, if somebody has cancer and they are on chemotherapy and the person start vomiting, what drug do we give, right? Ondansetron.
Ondansetron.
Correct. And then that ondansetron is blocking this 5-hydroxytryptamine serotonin receptors. So ondansetron, and that is one that now if you are giving ondansetron and it's not working, what would you give? I think it's called aprepitant or something. Aprepitant or something. So if you are giving ondansetron and it's not working, you want to go for this. Let me check it quickly and get a spelling for you. So I remember you would ask a question like that. They were given 5-hydroxytryptamine, which everybody knows. Yeah,
That's wicked.
Yeah, aprepitant. There's T at the end. Aprepitant, and mechanism of action is it blocks neurokinin. This one, neurokinin 1, right? Aprepitant, it blocks neurokinin 1, right? So it's something that you also have to remember. All right, let's move on to the next page. All right. I'm just giving you high yield information. Yeah. Here, so they love this topic. They want you to know that if somebody if a child is having night terror, right, what stage of sleep are they in? Now, if they're having a nightmare, what stage of sleep are they in? So what I know is that when somebody has a nightmare, how do you know it was a nightmare versus how do you know it's a night terror? The child wakes up and remembers everything. It's a nightmare. The child wakes up and does not remember anything. It's a night terror. You get a difference?
Remembering everything is nightmare.
Yes.
Night terror, you can't remember.
You don't remember anything. Now, so you want to know that this night terror is part of the non-REM. They don't remember, non-remembrance. Sorry, that's my way of remembering, right? And then because they remember everything, it's a REM sleep, remember sleep, right? Although it is rapid eye movement, but I use that as REM, remember. REM, they remember, so it's nightmare. It's not so severe. Night terrors are so severe. So it is a non-remember. They don't remember. That makes sense, right? And then over here they have the delta wave. You want to understand it. That is a very deep. They are so deeply asleep, so it's a delta wave. That's why they don't remember anything. And that's where you find them. They are sleepwalking. They get up, they walk, they are knocking their head against the door, but they wake up and you tell them and they say no, they didn't do that. They don't remember anything. Now, here, what you want to know that they love to ask on this side here is the changes that comes with the elderly. You know, the elderly people, they love to sleep a lot, right? And yeah, elderly people, they love to sleep. And then is that so? Is that correct?
No, sometimes they love to sleep, but sometimes they're not able to sleep.
So
They
it's
wake up in the middle of the night. They don't fall asleep easily, and then they wake up very early, just as it's here.
okay.
So they start complaining about. They wake up like 3 and they can't go back to sleep again.
Okay. Yeah. So it's on and off. Yeah. And also you want to the people who have depression. Depression, we know definitely sleep problem is one of the symptoms, right? But mostly the depressed patient would sleep more. So there is decrease in the REM.
They just want to sleep.
They just want to sleep. Decrease, so they have increased REM sleep time. They sleep a lot, and then they have decrease in the REM, the latency. Latency is the time taken for someone to fall asleep. So because they sleep frequently, the latency shortens in the depression. And it looks like that is the opposite in the elderly people. Is that so? If I'm looking at what I'm seeing, elderly people have increased in the REM latency. So you are right about you are saying that they have trouble even falling asleep because the elderly people have the increased sleep latency. So it takes a longer time for them to fall asleep, the elderly. So depression and elderly people are almost opposite.
Okay.
Yeah. So you are right about that. All right. So they really test about it. Someone has depression and which of the four effect on sleep, decrease in REM latency. D for decrease, right? D for depression, D for decrease in the REM latency. All right. Um, okay. Yeah, later when you have time, you want to see some of this, the nuclei, the hypothalamic nuclei. I'll wait for you all to bring your attention to it. If you see some UWorld questions on it, you want to come back here and look at it. Let me see, the one that I would want to remember the most are this one here, here, vibration, pain, sensation. It's gonna be the ventral posterior lateral nucleus of the thalamus, right? Because we said that the main function of the thalamus is sensation, and most of the sensation are what is listed over here, right? And when you go to the one above also, you want to look at which one affects eating and hunger, right? Eating, hunger, very important that you know which of the nuclei affect them. All right. So the limbic system, as we know, the limbic system is responsible for control of all these 5 F's, right? Feeding, fleeing, fighting, sex, and feeling. Yeah. So usually what they ask about the limbic system, the main thing is when there is distraction of the hippocampus, right? When there is distraction of the hippocampus, when there is a distraction of the amygdala, what happens to the patient, right? If there's what now, before then, what is the function of this hippocampus? They love to ask about what's the function of the hippocampus. It's mainly for memory. When we go to school, it's just for, we go to the campus, right? It's just for memory, to go and get a lot of information to our brain. So hippocampus is for memory. So if they ask you any question about any patient suffering from anything and they have memory problem, they'll ask you which of the following part is affected. It's gonna be the hippocampus. Yeah, the hippocampus. Now, there are some patients who have the Kluver-Bucy syndrome, where there is distraction of maybe the bilateral amygdala, or over here, this area here, there's a distraction of this area here, and mainly is the bilateral amygdala, right? And so those patients, will have problems with all this thing. Usually it's going to be sex feeding, right? So what they will do is that they'll be eating a lot. They call it a hyperorality. They eat a lot, and sometimes it's food, like they are just hyperphagic, they are just eating. But in order to trick you, they'll tell you, oh, this patient was not chewing gum, but now he loves to chew gum a lot, right? So in that case, your mind might not go to the fact that he's eating a lot. No, he's just moving the jaw. Something is just telling him to move the jaw. So that's hyperorality. He wants to put something in the mouth. Then they also have this abnormal sexual interaction with females. They want to be flirty with females, maybe the nurse or health workers or any female around. If it's a man, right? If it's a man. So that's how the symptoms will present to you. And it is called a Kluver. Maybe we'll see it later. Kluver-Bucy syndrome. And remember, Kluver-Bucy, remember, it should be bilateral. It should be both sides must be destroyed to have the Kluver-Bucy syndrome. That's a big thing that I'll take from here. Do you have any question?
It's not here.
Start again.
It's not here.
The Kluver-Bucy? Yeah, it will be somewhere ahead. It will be somewhere ahead.
Okay.
Yeah, it will be somewhere. But just because it's high yield, when we meet anything, I'll just let you know. Okay.
And I've written it down.
Okay.
I was just saying, just to confirm that not everything is in FA.
Yes. Yes. It might be hiding somewhere, maybe later on, but yeah. Because you know how sometimes you go and meet the thing like far, maybe even a different chapter, right? So I love to just talk about it as we go. You get a presentation, right? If somebody has,
go
ahead.
If you have, it has to be bilateral. They have problems with feeding.
Yes.
They can eat too much, or they can present with just putting something in their mouth, like chewing gum a lot.
Yes.
And then they have abnormal sexual drive.
Yes. Yes, they are.
Think about Kluver-Bucy syndrome.
Yes, and since the whole limbic system is there, they might also have memory problems, and they just have change in personality, excessive eating, and sexual abnormal sexual behavior. That is why you used to know that this person might have Kluver-Bucy syndrome. Yeah. Now let's look at this side here, the dopaminergic pathway. So this dopaminergic pathway, most of the antipsychotic drugs affect it. Parkinson disease, the movement disorders, and I would send you a video to watch so that you can look at the this pathway. Where's the name? This basal ganglia. I will not dwell so much on it to pass step 1, but it will just be good to look at it at least once, right? The basal ganglia, the pathways that the direct and then the indirect pathway. If we want to talk about it, I have to take all our time, but what you want to know is that before any movement is generated, let me see, I think it's on the next page. Did they take it from the book? It looks like they took it from the book. Let me see. Okay, it's here.
Yeah, that's one.
Yeah.
The basal ganglia.
Yeah. So before any movement is generated in the body, It goes through like complex stuff. Like yeah, it's we cannot
Mhm.
explain it right now here. And so I'll send you a simplified video so that you'll look at it just to have an
Okay.
idea about it. But so you want to know that we have the direct and then the indirect pathway. Direct pathway is initiating movement. Indirect pathway is always trying to inhibit that movement, right? So if you see the image, they use this then to for the arrows. But then each of the pathways, dopamine acts on it. D1s are always stimulatory and D2s are inhibitory. These are the receptors. So if dopamine acts on D1, it's going to stimulate the pathway. If dopamine acts on D2, it's going to inhibit the pathway, right? And then D1 will be for the direct pathway, D2 will be the indirect pathway. So let's go up again so that we look at what was the important stuff here. Okay. So what you want to know here is that if somebody has if somebody is schizophrenic, right? We know how they behave, right? They are so aggressive. Is that correct? They are throwing stuff. They become so strong. Yeah, so excessive energy. So that aggression and then like the strength that they have in their muscles to attack people and all that, it is coming from the brain and the neurotransmitter that works for them to that is helping them to do all that is dopamine. Dopamine is that active neurotransmitter. So that is why we have to give them antipsychotics. And most of the antipsychotics are working on dopamine. They are working to modulate dopamine. So they are anti-dopaminergic. They are inhibiting the D1 because we said D1 is always stimulatory, right? So it stimulates the psychotic patient. Now, they have negative symptoms and they have positive symptoms. And these are the positive symptoms: delusions, hallucinations. Later on, we can see how we can diagnose this when we come go to the back of the page. Also important.
Schizophrenia.
Yeah, because you have to know, they want you to be able to differentiate schizophrenia from schizophreniform, right? Disorder, and also schizoaffective, using the symptoms and also the duration of time that the symptom has been going on. But of course, schizophrenia, we need, I think, some of the positive symptoms and some of the negative symptoms, but it should be going on for at least 6 months before we can diagnose schizophrenia. But we'll look at that later. And so, what you want to know is that the mesocortical pathway is what is causing the negative symptoms of energy, apathy, lack of spontaneity, anhedonia, and all that. And the positive symptoms are the mesolimbic. So what the way I remember is it's like the limbs, right? They are so active and they throw their limbs, they hit people. So that is the positive symptom. So the limbs are so active. So the mesolimbic pathway, they love to ask you, they just want to know, like the answer would just be mesolimbic pathway. What is being affected, or which of the following pathways is causing these symptoms is the mesolimbic. The mesocortical are just for complex processing of the brain. That's the cortex of the brain itself. If like the surrounding, let me use this diagram. The cerebral cortex itself, that's the mesocortical. Yeah, so here or here, the cortex itself, that's where the mesocortical will be affected. And then the mesolimbic will be the substantia nigra area. That's where the dopamine is made. And yeah, so you want to remember that Now, next thing is the nigrostriatal pathway. Of course, that is for movement, right? The nigrostriatal pathway. And as I said already, dopamine is made in the substantia nigra. Is that correct? Dopamine is made in the substantia nigra, which is just the top of the midbrain. The midbrain is made in the midbrain, and so if you look at the midbrain, there'll be some black things over there at the center. If we look at a colored image, that'll be the substantia nigra, and dopamine is made over there. And so if they have symptoms of dystonia, akathisia, and all those tardive dyskinesia, which are extrapyramidal symptoms when we give them antipsychotic medications, like so any drug that affects the if they start giving them antipsychotics and then they Lagactil and all that, and they start having this, it is because of the nigrostriatal pathway is being affected. And the tubuloinfundibular pathway is also has to do with the prolactin synthesis, right? So that if this pathway, when dopamine acts on this tubuloinfundibular pathway, is supposed to inhibit production of prolactin, right? So if that pathway is not there, say somebody is having a prolactinoma, or somebody is being on antipsychotic, and the antipsychotic is blocking dopamine from acting on this tubuloinfundibular pathway, then the inhibition will not be there, so they'll start making a lot of prolactin.
They have present with galactorrhea and gynecomastia.
Exactly. Now, my question to you now would be, if a female presents with prolactinoma and a male presents with prolactinoma, what will be the difference in a male presentation of prolactinoma and a female presentation of prolactinemia? Do you have any idea how it will present, so that they can ask
Does
you
it
a
have to do with
question?
their sexual presentation dysfunction?
Yes, definitely that is part of it. But what I want you to remember is that if the question is going after, say, a male who has a prolactinemia, a male will never present with galactorrhea. They will not have breast milk from their breast. And they want you to know that a female can have that, because females already have their mammary gland, which is modified for that, but males don't have that secretory part of it, right? So they'll give you the question, and then they'll tell you it's a male, or this, that, you know that it's a prolactinoma, and they'll say which of the following symptoms is expected in the patient. If you choose galactorrhea, you'll be wrong, but if you choose it for a female, you'll be correct. It makes sense, right?
Okay.
Yeah. All right. Then other symptoms will follow. Of course, if they have excess prolactin in a female, prolactin blocks the GnRH, right, growth gonadotropin releasing hormone. Therefore, our LH and FSH will be low. If it's low, then they cannot develop the follicles to even reach the Graafian follicle level, so they cannot have the menstruation and all that. So infertility as well. All right. Is the speed okay for you?
Yes, I'm
All
okay.
right. All right. If there's something that we don't understand, like I can slow. So this is the cerebellum down here. So cerebellum, there is a lot about cerebellum, but we'll throw light on some of the stuff. We have to know the main function of the cerebellum, and then if there is a disease of the cerebellum, what would be affected. I think about cerebellum as why is it positioned at the back of the brain? It is here. Why is it positioned at the back of the brain? So that it can receive all the sensory information, right? It can control the back of the body. That is how I look at cerebellum. So everything moves from the back, so that the spinal cord, if you look at the spinal cord, the posterior column of the spinal cord, let me see if I can still draw spinal cord. Yeah, if you look at the spinal cord, the posterior column of the spinal cord. So if you look, we'll look at that later. Let me see, we'll soon get there. But then the dorsal column, all the impulses that go, they climb and go into the cerebellum. So if you look, that is those from the white matter, right? Not from this side, not from the nucleus part, but from here. So like if you talk about the here controls the arm, and then the arm and the leg. So the if I want to draw it, so let me draw it again. So I'm just taking this as this. Then you'll see that we have this is divided this way into 4. So this 2 here, outermost, will be controlling the arms, just like it is positioned on the body. The arms are outermost, right? And then the legs will be the innermost. So this will be the gracilis for the legs, right? Gracilis. If you and then we'll come to that. We'll talk about the proper map. I'm just bringing your mind to it. And then you have the arm, which is the cuneatus? Yeah, gracilis, and then the cuneatus. Yeah, but then what I want to tell you is that because it's positioned at the back, and this also the dorsal column. The dorsal column impulses are going to go into the cerebellum, so that they can help us with balance and all that. So mainly some of the functions of the cerebellum for balance, mainly of the trunk, right? Of the truncal ataxia, if there is a problem with it. And what other function can we talk about the cerebellum apart from balance?
Balance, that's coordination and balance.
Basically coordination and balance. Coordination and balance. So, and then this rapid alternate movement, right? This is it. Rapid alternate movement of the hand. If you want someone to rapidly like flip the hands, if they have a problem with the cerebellum, mainly they are not able to.
Like the one that I said, do like this.
Say that again.
You're using the other hand to do. I think you are doing play with it.
Yeah, like okay, tell someone to tap, use the palm, like you want use the palm to touch the palm something, and use the back of the hand again to touch, like in rapid alternate movement, right? Yeah, like touch the palm, touch the back of your hand, alternatively rapid. You said they cannot do it. They cannot coordinate that, so they can't do. And that is what is this diadochokinesia. This diadochokinesia, they are not able to do rapid alternate movements. Finger to nose testing will also be a problem, right? Heel to shin will also be a problem, right? Because at the end of the day, anything, the ears help in balance, the eyes help in balance, and also the cerebellum. But at the end of the day, they all have to send their impulse to the cerebellum to coordinate and interpret. So if you remove the cerebellum, even if the eyes are open, still it will be hard for the person to balance themselves. But if you remove the ears, right, and then their eyes are open, they can balance themselves, right? If they have maybe a B12 deficiency where they cannot perceive the nerve impulse, or they have diabetic neuropathy, but because the eyes are open, they are able to perceive, they're able to balance themselves. So what happens that we need at least 2 of the sensory inputs for balance. So we need the eye, we need the ear, and we need the peripheral nerves, right? Peripheral nerves. So at least we need 2 of them, and these all send their impulses to the cerebellum, all of them. Any two of them, the person will have normal balance. That is why when someone comes with, let's say, a peripheral neuropathy, and we want to see whether they have balance, we need to take another one out. So that's why we tell them to close their eyes to perform a certain function. So close your eyes and stand, and let's see whether you fall or not. If we remove this, the eye, and then they have peripheral neuropathy, they are going to have balance problems. It makes sense, right?
Okay, yeah.
Mhm.
That's the Romberg test.
Yes. Rombex. Rombex, yes. So the cerebellum, it has some nuclei inside. So we have the like this deep nuclei of the cerebellum, right? And here they are, the dentate and belliform, globus and a fastigia. And there's a mnemonic that they used to say, I don't know if they have it here.
Don't eat greasy foods.
Exactly. Don't eat
I
greasy.
have it in my house. Don't eat it.
Exactly. Don't eat greasy food. Oh, it's here. It's down here. Don't eat greasy food. So that is how, just to remember, which is deepest from don't eat greasy food. Yeah. So you want to know that people who have cerebellar atrophy, alcoholics, mostly alcoholics, their cerebellum becomes so atrophic over a very long time. So that is one thing that you want to take note of, alcoholics. So I think we talked briefly about this basal ganglia. It's a whole topic on its own. It's a whole topic on its own. But you want to know the like which nuclei makes what nuclei. So you want to know the putamen caudate nucleus, and the lentiform nucleus is the putamen, and globus pallidus. Striatum is the putamen and caudate. So here also there is something that you want to remember: the caudate nucleus. What disease affects the caudate nucleus? You have to know that.
Is it caudate nucleus?
Say that again.
No. Is it confused between Parkinson and Alzheimer's?
Okay, so it's gonna be Huntington
Oh, the Huntington disease. Okay, yeah, that's true.
disease.
Yeah,
And it's called Huntington chorea, right?
Huntington chorea, yeah.
So
Huntington disease, Huntington chorea.
Yeah,
Because of choreoformic
movement, the choreiform.
choreoform.
Yeah, and so in order not to confuse, if you like to borrow my mnemonic, I call it, instead of calling Huntington chorea, I call it Huntington caudate, right?
Okay.
Huntington caudate, just to, and because caudate is
Remember where
exactly
the problem is.
exactly Huntington caudate. Just to remember what the problem is. Very important you know that. The caudate nucleus, Huntington caudate. And with this, I'll never forget it, right? So I'm lending that to you.
Thank you.
Welcome. Okay, so basically that's something that you want to know from here. Let's go Huntington caudate. And if I want to go back a little bit to the page that we saw, this where I told you the CNS myeloraph, you remember that mnemonic?
Yeah.
CNS
The
myeloraph.
acetylcholine,
Good, exactly.
CNS or ANS myeloraph.
Yes, ANS myeloraph. I started using the CNS before I came. I'm like, oh, I could have used the ANS, you know? So it's like the CNS has remained in my head. But you are studying, so you can use the ANS. So now here, we didn't talk about here because once that this thing has shown up, right? The Huntington, because we saw the Huntington disease. So where is it? Yeah. Where is it? So now you want to know, like, when we know where each of the neurotransmitter is produced, we know this, but now we want to know if the neurotransmitter is not made or that part of the brain is diseased, what disease comes with it. Does it make sense?
Yeah.
Yes.
So if the midbrain or the substantia nigra is destroyed, we'll have problem. That's when we have Huntington disease.
Yes. Is it Parkinson, right? Substantia nigra. Substantia nigra. Is that correct?
Yes, substantia nigra. So if there's problem with substantia nigra, then because I'm looking at these arrows.
This one. Parkinson.
Yeah, it's decreased in, for Parkinson, it's decreased.
Yes.
In dopamine.
No, in Parkinson, here, okay, you're looking at this one. In Parkinson, it is decreased. So Parkinson disease, they define it as an imbalance between acetylcholine and dopamine. That's the imbalance, in the sense that dopamine is supposed to act on D1, right, receptors to initiate movement. But acetylcholine should modulate, they should be in a balance. Acetylcholine should be able to modulate that same movement, so that you realize that, give me a minute, let me just see if I'll see this. I might have it somewhere. I'm not sure I wrote it down, but okay, so I can make an illustration since I don't see it. Let me make the illustration here for you. So you realize that they are supposed to be in equilibrium. Like, this is acetylcholine, and then this is your dopamine. And if they are on, if I put them on something, like if you're balancing them, there should be an equilibrium, so that if any of them is too high, you are going to have a movement.
Tilt the balance.
That again?
It tilts the balance.
Yes, it tilts the balance. So movement in our body initiated from the brain should have a balance of acetylcholine and dopamine. Now, in someone who has the Parkinson, there is a distraction of there's decreased production or distraction of in the midbrain, specifically the substantia nigra area, right? And so you notice that they will have a decrease in the dopamine, so the balance is gonna tilt this way. Let me see. It's gonna tilt this way. The scale will tilt this way. So there's decrease in the dopamine. Dopamine decreases. Let me put the dopamine here. It decreases. And acetylcholine rather is high. Does it make sense?
Okay.
No, I made a mistake, right? The higher one should pull the thing down. So acetylcholine will be here. Does it make sense?
Yeah, because it's higher than the lower one will push. It's like a seesaw, like those children doing seesaw.
Yes. Yes. So
the heavier one.
The heavier one. So here will be the acetylcholine, which is the heavier one, and then the dopamine decreases. Which so it causes imbalance. So if acetylcholine is supposed to increase your movement, and now so the person will be moved, and then dopamine is supposed to modulate, right? Now dopamine is going to modulate them, but the acetylcholine, acetylcholine is going to modulate their movement, but then dopamine will not be there to initiate their movement, right? So you see that's why they have is it cogwheel rigidity, right? Cogwheel.
Yeah.
They won't take a step, they cannot take the step. They cannot take the step, like that. Yeah. And we are seeing the opposite for Huntington, which have the coriform movement. They have increase in dopamine, because dopamine increases movement, and the acetylcholine is not there to stop the movement. Right. So we have to coordinate them this way. Probably I think I've changed the explanation, but I think you understand what I mean, right?
Yeah.
Yeah, there should be a balance between acetylcholine and so mainly
Dopamine.
acetylcholine is to reduce movement, dopamine initiates movement. So if acetylcholine is too much, then your movement is going to be slow. If dopamine is too much, your movement is going to be too fast. Right. That is why Huntington will have fast movement, whilst Parkinson will have slow movement. But they are all problems. So this is what I wanted us to take note of. Now, the RAF nucleus or RAFI nucleus, serotonin, what is it implicated in? Depression. Right? Serotonin is implicated in depression. Now, this is another thing that I don't know if I have a mnemonic for this also, so that if you know where it is made, if you know the CNS myeloraf, then you also want to know what disease they affect, right? CNS myeloraf. A panic depression. Yeah, a panic depression. Okay. Yeah, I don't think I made a mnemonic for you. If I see it, I'll send it to you to help you remember what disease will also be affected with the mnemonic, right? So that if you know ANS, yeah,
Myeloraf.
yeah, ANS, where is it? Is it this one? ANS, myelor, this is the S, right?
ANS, yes, ANS. And then
Myeloraf.
the
Myel.
S is the RAF,
Mhm.
the N is the locus coeruleus, and the ANS is the minor basal nucleus of the minor.
Minute. Basal nucleus of the minute. Okay, yeah. Then the next thing that you have to know is that this has to do with the norepinephrine, some has to do with the panic disorder.
Panic attack.
Yeah, because there are a lot of panic disorders.
Right.
Yeah, so all the panic disorders, they affect this locus coeruleus. Serotonin affects depression, right? So if somebody has depression, it is serotonin and it's a RAFI nucleus. If someone has panic disorders, it is going to be the locus coeruleus and it's norepinephrine. And if someone has this one, then acetylcholine, that one we can know is Parkinson and Huntington, interchangeable, like not, I mean, we can correlate it. So Parkinson and Huntington. So I want a hunter needs to move like fast to get its game, right? Or to get its animal to kill, right? So it makes sense,
Yeah,
right?
it's in biochemistry.
Exactly. But a park, like we need to park a car, right? We need to, like a car,
You
if you're
have to go
parking a
slow.
car, it has to go slow. That is why we'll have less dopamine. So all you have to know is that dopamine is for increased movement. So if dopamine is for increased movement, if it's decreased, you are going to park the car. If it's high, you're going to hunt. You're going to move fast to hunt. So that solves that problem for us. This is a very high yield topic.
Oh, Parkinson, go slow, then you park.
In park.
Huntington, you have to move fast,
yes,
to get your kill.
Yes. Okay. Right. And to move fast, we need dopamine, right? We need high dopamine.
Yes.
To move slow, we need slow dopamine. But don't forget that there should be a balance between acetylcholine and dopamine. That is why,
in a normal situation.
Yes. That is why when we are treating a disease like in Parkinson, because they have low dopamine, we can give them levodopa so that they have more dopamine in their brain. It makes sense, right? Now, if we also don't want them to have more dopamine and we want to rather decrease the acetylcholine level to come to their level, the level of the dopamine, then we can also give an anticholinergic drug, right, to also lower the acetylcholine. So let me go what anticholinergic drug can be used to treat Parkinson.
Parkinson.
Right? Yes. It makes sense, right?
Yeah. I mean, like you said, once you know it, you reason it out,
Yes.
then life could be a lot easier rather than cramming it.
Yes, rather than cramming it. So yeah. Yeah. So benztropine for Parkinson, right? Because we said Parkinson has is Parkinson, so low dopamine, but high acetylcholine. So now we can lower the acetylcholine so that they have treatment of their symptoms, or we can increase the dopamine so that it's still at the level. It makes sense, right?
Yeah.
All right. And it's the same applies to
is it benzodiazepine?
No, benztropine is an anticholinergic.
Benztropine.
Yeah, like atropine, right? Atropine, benztropine.
Okay.
Yeah. I think we'll not give atropine because maybe it has a very short half-life. So it might even enter the brain.
Okay.
Yeah. But benztropine. And then another one that is not common, but they love it, is a trihexyphenidyl. 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 They love this one. You will not find benztropine. You'll find this one.
What about donazepam? What do we use donazepam for?
Which one?
Donazepam.
Can you spell it for me? Is it Donapixel? Donapixel. Is it Donapixel? This one? Donapixel is for Alzheimer's.
Okay.
It's called Donoriva-Gala. Donoriva-Gala. So all these three are for Alzheimer's. So donepixel, rivastigmine, and galastigmine or something. Galastigmine or galastigmine. Donoriva-Gala for Alzheimer's. Right.
Okay.
And they are acetylcholinesterase inhibitors so that we can have high acetylcholine in their brain. Just opposite to this. It makes sense, right? So they are the enzyme inhibitors, acetylcholinesterase. Acetylcholinesterase.
So they destroy in the neuromuscular junction.
Yeah, in the brain, actually.
In the brain.
Alzheimer's is in the brain, right? Yeah. But in the neuromuscular junction, they'll rather give the pyridostigmine because each of the drugs has its own property. So for some reason, maybe the rivastigmine can go into the brain, but the pyridostigmine can stay in the neuromuscular junction.
Okay.
But they're doing the same enzyme, killing the same enzyme.
Depending if they can cross the blood-brain barrier.
Yes. Yes. Exactly that. So we've exhausted this page, all right?
Yeah, we came back to that page actually.
Yes, we came back. Yeah, I think it skipped me when we were doing it. I'm glad we really came back to it. And then if you watch the video again, you will see it.
Okay.
Yeah. These are very high yield topics that I'm telling you. All right, so where were we? Past here.
We were in the cerebellum.
Cerebellum. Yeah, we're going to move from there.
I think what took us there was we were talking about balance. We need the cerebellum, the eye, the ear, and the PNS for balance. And then we're talking about rapid pronation, supination.
Yes. And here, you want to know that you see how they've put this here. This is the flocculonodular here, the green one. See how the cerebellum is balancing on it?
Okay.
That is the main one for balance. That's the main one for balance. Main one for balance.
The green.
Yeah, the green one.
Oh, yeah.
Flocculonodular. Yeah, that's the main one for balance. And then I think this one is the vermis here. The vermis is here. I think that is for, I shouldn't be thinking, right? Yeah. So here they've put it here. So the medial lesions which affect the vermis and then the fastigial nucleus, right? They have to do with the trunk. So wide
truncal ataxia,
nystagmus, head tilting, nystagmus and head tilting. So some of the deep nuclei here, plus the vermis, they are for the truncal ataxia. And just so I would put this, like, just align this with our body. Okay, you see how the trunk is in the middle of the body, right? It's the same organization. The trunk is in the middle of the body, so the vermis is in the middle, like that. And so with the limbs might be this, the peripheral nuclei
to the side.
Yes, to the side. And yeah, and look at it. So they've said it over here. So the lateral lesions, they affect the voluntary movement of the extremities, right? So that's what I do. Like when I was doing step 1, I would just imagine myself lying on top of the cerebellum and spread my arms wide, right? So my arms my arms go to the lateral nuclei, and my trunk is lying on the vermis.
Okay.
Yeah.
So anything that affects the vermis causes truncal ataxia.
Exactly. And then we had said in the Chiari 1, right? And 2. So Chiari 1 was for the tonsils, right? The tonsils alone. And then the 2 was for the tonsil plus the vermis. So those who have the 2 also have truncal ataxia. All right. Alrighty. Okay. So this is another part that they want us to know. They love to also test on the organization of the cerebral cortex, right? With this one, later on when you start doing questions, we'll need a CT scan to be able to predict the symptoms. That's the best way. That this one does not really help, but then you want to be able to always locate your central sulcus. It's very important to locate the central sulcus. Very, very important. Then you know that towards the back, so this is the front and this is the back of the brain. So we'll have the primary somatosensory here. Then this side will be the motor cortex, the primary motor cortex. But first of all, you have to locate the central sulcus. If you don't locate it, you'll get the question wrong. So sometimes they'll give you the CT scan of the brain, then they'll label here A, B, C, D, right? Then it will tell you that the patient's symptom in the question, which of the following areas of the brain is the lesion affecting? It makes sense, right? So you have to know, is the symptom mainly sensory symptoms? Sensory, or is the
It's going to be
symptom?
towards the back after the central sulcus.
Exactly. So you have to know, is the symptom motor or is it sensory? But then even if it's motor or sensory, you have to locate the central sulcus to be able to pick A or B, because if you put the central sulcus here, then your answer becomes something else, right? If you put a central sulcus here, your primary somatosensory will come to this area rather. So you'll be choosing.
Come to the parietal.
Exactly. So very important. Very, very important. If you remember that, to help a lot. Yeah. And other than that, there's another thing that you want to also pay very close attention to. Very close attention to here, the temporal lobe. The temporal lobe is very important. So you want to know the Broca area. They'll have, if there's a problem where they don't have broken speech, Broca for broken speech, they'll not be able to talk very well. And then the Wernicke's area, also very important to know. Not just knowing the function, but being able to locate it when they give you a CT scan. So that if you can locate your temporal lobe, if you can locate your temporal lobe, right, you have to know that when you go, the Wernicke's is in the temporal lobe, but the Broca's is not in the temporal. Broca's is in the inferior frontal, right?
Okay.
Yeah. So Broca's is not in the temporal lobe, inferior frontal. Whilst this one, the Wernicke's in the temporal. So Broca's is for frontal, and Wernicke's.
So Wernicke's in the temporal lobe.
Yes. Yes. Yeah.
Oh, yeah, sure.
Anyway, you can also see that B, if you look at the alphabets, B and frontal are closer at the front, right? Whilst Wernicke's, W and T are also at the back. It makes sense, right?
Okay.
Yeah.
The Broca is closer to the front and the Wernicke is closer to the back.
Yes. If you look at it. Yeah. Like, I mean, if you look at the alphabets, right? If you're counting A to Z.
BF.
Right.
W,
W, and
T.
Yeah, towards the back. Right. So they move together. W and T move together because they are towards the back. The temporal and then the W. And also broker and then boyfriend. Yeah. Okay. And also later on, you will see some of the symptoms of each of the areas as well. So that, like, if somebody has like a problem with the frontal lobe, what is the main function of the frontal lobe? Mainly it's for executive functions and decision making, right? Mainly. So they'll have problem with executive functioning and they cannot do some decision making. And also the cortex here, the visual cortex, if they hit you from the back, right, they also have problem with vision. We'll see more about that because we'll come to where all the tracts move and all that, and we'll talk more about it. Let's see here. This is high yield. So you see, everything is high yield. Everything is high yield, but what we are doing is really going to make it easier for you. Are you ready for here?
Yeah, I tried.
How
The
did it
PCO2, the hyperventilation, and all that.
Yeah. So basically, what you want to know here is just the, you know how in the lungs, if somebody does not get a lot of oxygen for a long time in the lungs, like um, hypoventilation and all that for a long time, they'll start having, what happens to the blood vessels in the lungs? It's having vasoconstriction, right?
If you have if you have hypoxemia or
Yes,
reduced oxygen, then probably vasoconstriction. But if
yes.
you have a lot of PCO2,
Mm.
hypercapnia, you have then that dilatation, vasodilatation.
Vasodilatation, right? Okay. So in order to, like, when I'm approaching questions like this, because sometimes they'll ask you, okay, this happened in the patient, and what do you expect? Because a patient can come and then they put a lot of oxygen on the patient. What would be the effect of that oxygen on blood flow to the brain? Right. So that is how what they do, so that if somebody comes to you, the person is having head injury and is losing consciousness, we want to reduce the swelling in the brain, right? What should we do? Should we give the person a lot of oxygen, or should we give the person a lot of should we decrease the oxygen? Does it make sense?
Yeah, you decrease the oxygen so that you can have increased PCO2 so that you can have vasodilation so that the blood will flow.
So the blood will go to the brain. Is that what you want to do? If
No, I think you're trying, I think when there's edema,
Mhm.
you want the patient to reduce the intracranial pressure,
Correct.
and then you want to do hypercapnia so that rather than the blood, so that it will just retain, there will be a lot of blood in the vessels rather than swelling edema. That's where I understand, rather than the brain being edematous.
Exactly. Exactly. Yeah. So we want to decrease oxygen so that more blood does not flow to the brain like that. Yeah. So if we look at here, so therapeutic hyperventilation.
Ventilation.
So therapeutic hyperventilation decreases PCO2, and that causes vasoconstriction and decreases blood flow to the brain. That decreases the intracranial pressure. Is that is that how we understand it?
Yes, so that the edema will reduce.
The demand reduce. So that is what this page is mainly about. And usually they'll use present the patient in the ICU who has had a head injury, or just having signs of increased ICP. Yeah. So Cushing's reflex. So triad of hypertension, bradycardia, and respiratory depression in response to increased ICP. Sometimes they ask this also, increased ICP. So they'll give you the symptoms: patient has hypertension, has bradycardia, and respiratory depression. They'll ask you which of the following is most likely in the patient. For me, it was hard for me to notice this from questions when I was doing step one. It was very difficult for me, but the way they present the question, my mind never went to the question triad and the way they present it. Yeah, it was easier for a lot of people. Yeah. So cerebral perfusion, it relies on tight autoregulation and primarily driven by PCO2. So oxygen also modulates perfusion in severe hypoxia. So oxygen comes in severe hypoxia. Also relies on pressure gradients, the mean arterial pressure and the intracranial pressure. And we know that the cerebral perfusion pressure is the mean arterial pressure, which is the one that is, let's say, is coming from the heart, right, minus the intracranial pressure. So say the heart is trying to send the blood up, but the intracranial pressure is also trying to push the blood out of the brain. So if you subtract it, the final thing is what enters the brain finally. It makes sense, right?
Okay.
Does it?
I mean, looking at the equation,
Yes.
and if it is zero, then there'll be no cerebral perfusion and the brain dies.
Exactly. Exactly. That's why they must not be equal. So the ICP should always be less than the mean arterial pressure so that some blood can go into the brain. So we said this already, therapeutic hyperventilation, lower PCO2. Yeah. So the way I think about it are in the lungs, if you have increased PCO2, PCO2 in the lungs, you will have, if you have increased PCO2 in the lungs, you have vasoconstriction. Is that correct? No, you have vasodilation, sorry. Vasodilation, because it's opposite to this. You should have vasodilation. If you have increased CO2 in the lungs, you have vasodilation. In the brain is the opposite, vasoconstriction in the brain. So that if you have excess oxygen also, it's almost also the opposite, right?
In the lungs.
Yes, in the lungs. Mhm. So decreased CO2 is causing vasoconstriction. So when the person comes to the ICU, we want to do hyperventilation for them. We set the ventilator setting to so they have increased respiratory rate, increasing the respiratory rate. I think that's what they'll ask sometimes. So what would you do to increase the respiratory rate? And then that would mean that they'll have low carbon dioxide.
Increase hyperventilation.
Yes. So it means that carbon dioxide helps cerebral perfusion. True or false?
Yes.
You can flip
Decrease in the CO2 would lead to vasoconstriction,
Yes.
and that would decrease the blood flow, and that would help decrease the intracranial pressure.
Yes. So the opposite applies, right? So increased carbon dioxide can also cause vasodilation. Yeah. So if we want the person to have increased cerebral perfusion, we have to increase the carbon dioxide for them. So we decrease the respiratory rate.
And looking at the graph.
Yes. Yes. So this cerebral perfusion, yeah, cerebral blood flow. So if we increase carbon dioxide, then we have increased cerebral blood flow because this is the pressure. So let me see, increasing carbon dioxide increases cerebral blood flow, then decreasing oxygen, right? So yeah, decreasing oxygen means that we are increasing carbon dioxide like that. So it goes hand in hand. Yeah. All right. How to clean all this?
Interesting area to go to.
Like this area?
No. I flipped my book to the other page.
Oh, okay. We are getting there. It's good we build all these basics. And this is it this page you're talking about?
Well, yes.
It's okay, well, I wouldn't it's to me it's not the hardest part of the book, but
Okay.
let's do it. So you know what?
No.
Or which page are you talking about? Not here?
No, I said this is very interesting.
Oh,
You know,
okay.
when you do the legs and the
The homunculus.
hmm.
Yes. So here the main thing that we have to know is like always remember the homunculus. We put the brain let me go to the next page. Yes. Let me see if there's a better image. They never draw the brain the way I want it. Okay, let me see something here. So it's like the you know the orientation of this homunculus, right? Where is it? Yeah, the orientation. Always have the orientation in your mind in solving such questions. So um, so this person is lying with the legs in the around the corpus callosum, like where the hemispheres meet, right? Where the both hemispheres meet. So that is what he's doing. The legs around here, the middle of the brain where they meet. And then when we come towards the side, the arms are there, and then the face is there. What we should know, the most important thing is the vessel distribution, and that will give us our answer out. So in order for me to remember that, it also takes the shape of the body, right? How the body is oriented. Now, if you stand straight, your legs are in the middle. Is that correct? And your arms are outside. And your face goes with your arms. Like that, the face goes with the arms. So that is very, very important. Very important. So if we have this homunculus down, we should be able to predict most of the stroke syndromes, most of them, like what a symptom will be and what it will affect. But there is one scenario where everything will be affected. So instead of having only the legs affected in a stroke syndrome, you can have both the legs and also the arms affected and the face also affected at the same time. And the only time that happens is when you have there's a vessel here, the internal capsule area. Yeah, later we'll see the vessel that is affected, the internal capsule area. So that is the only time that everything will be affected. Any question that tells you the arms and legs are weak, it is due to this area, the internal capsule. But it will always be only the legs or only the arm and face together. So only the arm and face, that will be the MCA area, the middle cerebral artery. Then the anterior cerebral artery area will be for this side. Then over here also we'll have the what's the name of this vessel? I think I've forgotten the name of the vessel, but we'll see it so that we'll talk about it. Yeah. And the posterior cerebral artery area also, they don't too much about it, but you will see for that, you will see because the visual cortex is affected, you see something with vision itself. You have a problem with vision as well.
That's the posterior parts,
yes.
The visual cortex.
The visual cortex, yes. Yes.
So how do you identify the sulcus here?
Over here?
The sulcus,
the central sulcus? Which one?
The sulcus between the purple or the green and the blue and the green.
Oh. Oh, like here. Let me see. Is it like over here?
No, like no, the purple. No. What is the central sulcus?
The central sulcus? Oh, I understand it. It's not clear in this picture. I'll lie to you if I show you. Maybe here. Okay. Yeah, but I'll lie to you.
Yeah, that's why I'm okay.
Yeah, there's a way they do it because everybody has like a little variation in the folding of the brain, a little bit. So so there's a certain line that they take from here, and then I think they'll look at this thing here. So, but we'll look at some CT scans later, if not today, but we'll look at some CT scans so that like they are from NBM images. They give some complex images. Yeah. And this is not a best diagram to locate the
locate the central sulcus.
Yes. Okay. Best image. Yeah. So here let's just focus on the blood supply. Yeah, the blood supply. So now you can tell me where each blood supply is, right?
But based on the coloration.
Based on the coloration, you have to have this color in your mind always. MCA, right? ACA and PCA.
In the PCA.
Yes. And you remember how I said the brain is organized according to the body, right? How the body is orientated. So the ACA, anterior communication artery, is in the middle, right? That's where our leg is.
Okay.
Then the middle cerebral artery area is outwards, right? The arms and the face always go together.
The arms and the face, yeah.
These are the most important that you have to remember. If it's still complex, you can use your arms to hold your head, the side of your head. Use your hands to hold the side of your head and point your head downwards. It makes sense?
Okay.
Makes sense, right?
Mm-hmm.
So once you put your hands on the side of your head, you know that the hands and the face are on that side. And if you look downwards, it's your legs that comes to the middle. But just that the vessels also don't follow, like the names of the vessels don't follow the same way. Yeah.
Okay.
And then these are watershed areas that cortical borders occur between anterior and middle cerebral artery. So like where the vessels meet, they call them the watershed areas over here, the watershed areas. And so that is the red. And so what they want you to know is that anytime there is hypoperfusion to the brain, say the person is in severe shock, right? They want you to know which part of the brain would be affected in severe shock. So the person comes, he's in this, there's something they call, yeah, like say the person went for surgery and is having, he came back and they said he lost a lot of blood, or he was involved in an RTA, road traffic accident, and he lost a lot of blood. The parts of the brain that are affected first are these watershed areas. So usually they want you to know that a junction between the ACA and then the MCA, and also a junction between the PCA and the MCA. It makes sense, right? So PCA over here and PCA over here, and then the MCA on this junction, but it's inside the brain, right? And also this junction between the ACA and MCA. So the MCA is just in the middle. So junction between the other side to it is what, but it's under the brain. Yeah, not on the cortex outside, but subcortical. So they are the watershed areas. And what symptoms are we going to see? We'll see upper and lower extremity weakness, right? And then they call this man in a barrel syndrome. And that one also will see visual problem, right? Because we also have the vision at the back over there. If you look at this image, yeah, they have higher order visual dysfunction. But this is the one that they will most likely ask. So after surgery, or after RTA, you treated the patient and everything. Now he's having upper and lower extremity weakness. It's because the junction of the ASA and then the MCA are affected. And ACA will come with what symptoms? The leg symptoms. MCA will come with the hand symptoms. Okay. Do you have any question here?
No, not for them.
Okay. If you have any question, you can stop me.
Okay.
Have you done this circle of Willis? Have you done the circle of Willis?
Yeah, I've done the circle of Willis. You were asking me where when you have an accident, or we spoke about intima and the circle of Willis, and it's between the anterior cerebral artery and the anterior communicating. When there's a bridging vein that causes subarachnoid hemorrhage, hematoma.
So bridging vein will be, is it a subdural, right? Or a subarachnoid? We have to get that clear, because if you miss the word, you are likely to miss the question.
To miss the question.
Yes. So bridging vein is subdural.
Oh, aneurysms.
Okay.
The aneurysms, that's where you have problems with the intima. And that's when you have people that have Marfan syndromes that can
Yes.
have bleeding of the berry aneurysm.
Correct.
Sorry about that.
Yeah. So there will be more of the subarachnoid, right?
Arachnoid hemorrhage.
Yeah.
Not subdural hematoma.
Exactly.
Yeah. Sorry about that.
It's okay. So if I do, this is just a question, we are not there yet, but if I do a lumbar puncture, can it differentiate subdural hematoma from subarachnoid hematoma?
If you do a lumbar puncture, because of the subdural hematoma, because it crosses suture line, I think it just goes, and then that's when you can, let me try. So because of the epidural, it doesn't cause the suture lines, but in the subdural, it causes the suture line. I think then you can now see those changes in the blood. It goes into the blood. It goes when you do a lumbar puncture, then you find blood there.
Okay, in which of them? In the
subdural hematoma.
Okay, so I was asking yeah, okay. So why I'm asking you this question is that I want you to know that the CSF, the brain is swimming in the CSF, right? Is that correct?
Yes.
The CSF is around the brain. Now that CSF, which of the layers do we have? So which of the dural, the covering, the meningeal layers do we have the CSF in? You understand my question, right?
Yes.
Or we have the subdural space.
The layers of the meninges. Where exactly?
Where
Is the
exactly?
blood?
The CSF.
Is the CSF in it?
Yes. So it
I'll
is
say between the pia mater and the brain.
okay. Pia mater in the brain. All right. So it's
supposed to be, CSF flows in the subarachnoid space located between the arachnoid, it's between the arachnoid matter and the pia mater.
in the pia.
Sorry.
Yes, exactly.
The pia and the arachnoid.
Exactly. As for the pia, it's like we'll call it you know how we have the like if we have a layer of something covering an organ, we have the visceral layer and the parietal layer.
Mhm.
The pia is just
I
like a
was
visceral
thinking that,
layer. It's just lying directly on the brain. So there's no like
okay,
almost like there's no space between the pia and the brain.
on
It's
the
lying
brain.
directly on it. Yeah. So
So
you
that's why the CSF is between the arachnoid and the pia.
exactly. So that's the subarachnoid space. So the CSF is there. Another reason why I'm asking
Okay.
this is I want you to know that the circle of Willis is floating in the subarachnoid space in the CSF.
Okay, and that's why if you have a subarachnoid hemorrhage, which is due to aneurysms or AV malformation, the blood will be in the CSF space.
That is
And
correct.
when you do the lumbar puncture, you'll be able to see bloody or yellow
Xanthochromia, right?
xanthochromic
Yeah,
in the CSF fluid.
that's
Will
correct.
appear like that.
That is correct.
Thank you very much. I
You're welcome.
mean, that's integrating it, and then otherwise, I missed it already.
Yeah, you're good. You're good. Yeah. Also remember that we need a timeline for the xanthochromia to occur because you need to be able to break down that we need to wait for the red blood cells to break down, right? To form the yellow pigment out of it before we can see the xanthochromia. So if someone has it right now, you are supposed to maybe if you see blood, it should be bright red.
To be bloody, yes.
But if it takes some time, then it changes color. All right.
Okay. So
Okay.
when it changes color, it shows that bleeding has been for some time.
It's been there for some time. Maybe more than 6 hours or 24 hours. Yeah,
Okay.
some time. Yeah.
Okay.
Mhm.
Very good. Very good. Thank you. Because I would have just gone home to sleep and like, oh, everything's hunky dory. I know everything.
Yeah.
This is ability to recall.
But I know
Okay,
the way we
thank
are
you.
talking about it, once you see questions, like even if you get a question wrong, like it will still come back. Oh, we talk about this, so this is how to apply it. You will be fine. You will be fine.
Okay.
Yeah. Um. So with this whole circle of Willis, there is they want you to know like each of the vessels, like if there's a damage or there's a hemorrhage of each of the vessels, what symptom would you see? At least we know these three already, right? We know one, we know two, we know three, right? Is that correct?
We know the PCA, the
Mhm.
MC, and the ACA.
Yeah, we know those ones, right? So my question to you is, if somebody has an MCA stroke, what symptoms would they have?
Then they will have more of the arm and the face.
Correct. All right. And ACA will be what?
ACA will have more of the legs.
More of the legs. This is good. Like, this is good. You've already gotten a lot of questions correct. Yeah, because you would loves the AC and the MC. They will drill you until you get it. That is how you would. I love you all for that. They'll ask you the same questions over and over and over until you get it.
In different,
Yeah.
using different, the same procedure, the same concept, or
Yes.
little bitty
Different
differences.
scenarios. Yeah. Yeah. And also later we will see, we will not do it now since we are still in the anatomy part. Later we'll see that if there's an aneurysm in the PCOM here, we'll see some symptoms like vision problems. We'll have ipsilateral blown pupils and all that. We'll see that later on. Now, if there is a problem, an aneurysm of the ACOM, the anterior
That's
communication.
the one I was saying. I think that's the one that causes the optic nerves, the
Yes,
optic chiasma, and then
yes.
yeah. I was watching a video before.
Oh,
Um,
okay.
I joined you about this high guru man.
Yeah.
Rahul, whatever. So I was talking to about that.
High guru.
Being
Oh,
high
okay.
guru.
Yeah.
Talking about what berry aneurysm, and you can see that in Marfan syndrome because they have problems with their media and media.
Yeah.
And that place, because it's turning around at that point in time, it's turning to become the anterior communicating, and then you can have flaws in that, and that's why they rupture easily.
Yes, that is true. That is true because anytime the vessel tries to anytime there's a joint in any vessel, or anytime a vessel branches, it branches because there's a weakness there. If there's no weakness, it will just continue going straight. So it needs to branch. It's like it has to join. And if you find a pipe, the weakest area of pipes are where there are joints on the pipe. Yeah. Yeah. So the same way here, the joints over here, there can be aneurysms here, aneurysms here. Yeah, anybody can have aneurysms. Anybody can have aneurysm. The most likely people in the normal population will be those who smoke. They'll be the most, because the cigar, a toxin, and all the free radicals are toxic to the blood vessel, the media. And then also, as you said, in the Marfan syndrome, and also in Marfan has another Ehlers-Danlos, correct? Ehlers-Danlos. So in Ehlers-Danlos, there's a type called a vascular type, right? They also have this problem where in Marfan they have the cystic medial necrosis. That one it has to do with the disease, cystic medial degeneration or something, cystic medial degeneration. You have to know that word, cystic medial degeneration. Once you see that, it's Marfan, like that. So that the degeneration of the media of the blood vessels, what makes it more weak. Even in normal people, it's weak already because of the branching. Then the person is smoking again, free radicals will make it more degenerative, and even they have Marfan or Ehlers-Danlos, more problems. But they are basically due to the collagen, right?
Marfan should be fibrils.
Yeah.
Fibrils. And then I think Ehlers-Danlos was more of a elastin.
Elastin. Yeah, but then
Elastic.
yeah,
Is a part of the collagen
synthesis. Yeah.
Collagen synthesis. Yes.
Where is that? Is it in biochemistry?
It's in biochemistry.
Yeah, because at the end they will all make collagen. Let's see. Let's see if we'll see. Do you want to look at it? Yeah. On page 52 in my book. So Ehlers-Danlos. Type 4 collagen. Type 4 collagen here. And
Okay.
so Marfan is a
Ehlers-Danlos.
So Marfan is a
collagen
fibrillin, right?
synthesis. Yeah, the Marfan is fibrillin. Fibrils, and then the Ehlers is collagen.
Collagen, correct. So you want to also know the type, right? The collagen type, that is collagen type 4 is for Alport
syndrome.
Alport syndrome. Okay, and then the type 3 is the Ehlers-Danlos. Is that correct?
Mhm.
Yeah, 3 for E, Ehlers-Danlos, type 4 for
In deficient in the vascular type of Ehlers-Danlos syndrome is type 3,
right.
because you have the type 3 collagen in the reticulin, and then you see them in the skin and the blood vessels.
Correct. The uterus, granulation tissues. Okay, that's just by the way. Menke is also the problems cross-linking. We have Menke and Ehlers-Danlos. Yeah, that this page is
Yes.
also very important.
Menkes will be something to do with copper buildup.
ATP 7B. Yeah.
Menkes protein ATP7A, that's absent copper, and then
Wilson.
B7B
Oh, is
is
a Wilson.
Wilson disease, and then there'll be the copper buildup.
Right.
That's due to the problem of lysyl oxidase, because copper is a necessary cofactor. And if it's absent, there'll be defective collagen development. Then the collagen, they'll have kinky hair.
Kinky hair. That's the Minky, right? The Minky has a kinky hair. Is that correct?
The Minkies have a kinky hair.
Okay. Yeah, Minky has kinky.
And they have increased risk of cerebral aneurysms as well. And Minkies.
The Minky.
Increased risk of cerebral aneurysm as well.
Okay.
So because of decreased activity of the lysyl oxidase that requires copper as a cofactor, there will be defective collagen cross-linking, and that will result in brittle, kinky hair, growth and development delay. They'll have hypotonia, and then they have the increased risk of cerebral aneurysms as well.
Okay.
So monkeys have cerebral aneurysm, and those two have the vascular type who have problems, and then Marfan's too, because of
the fibrillin cystic media.
yeah, they to have aneurysm,
Correct.
very aneurysm.
Right. Cystic.
So three monkeys, Marfan's, Ehlers, the vascular type, and the monkeys.
Correct. And if these same people smoke, then they are even worse.
The risk increases.
Yes. And then if they even drink alcohol, to their blood pressure will be high. So it also put more pressure in the vessels. So it's just not a good thing. Yeah, so later we'll see there is something called a rule of force that you can use to predict some of this the other vessels, like the Ica, pica, the basilar arteries, the anterior spinal artery. They love to ask them also. But these are more towards the back of the brain, the cerebellar area, and then the midbrain, pons, medulla area on this part over here. So they also have their symptoms, but they are more in depth. So I will share this thing with you later on, so that maybe if another day you want to look at it, right? Because we have to understand the brainstem decussation of all and then the movement of the tracts in order to understand, appreciate this well, like know the normal first of the brainstem before into the abnormal, the stroke syndromes. Yeah, here they don't test so highly on this one. Yeah, they don't really test highly on it. But what I would tell you to know is that just have an idea and know that all these vessels, like these are of the venous system of the brain, right? They drain and they go and enter into the internal jugular vein, right? And then this jugular vein will now drain into like the neck veins and going to the heart. So all the CSF that is draining from the heart will end up mixing with the blood in the right atrium. Right. It makes sense, right? It just tries to find its way into the heart and mix with the blood and then go into circulation. Yeah, but they don't really ask any big question on it. Here, they love it. Why do you laugh?
No.
It's hard.
No.
Okay.
It's just that it's complex a little bit.
Okay. Yeah.
And that's when they start asking pathology about cerebropontal angle, which
Yes.
now is affected, if it's in the pons and all that.
Yes. Okay, let's look at it. Let's finish and then you see, I hope you appreciate it when we finish. So, so in this, you know all the names of the cranial nerves. That's the first thing to do from 1 to 12. Because sometimes instead of them using cranial nerve 1 and code, they'll mention the names for you, right? Olfactory, right? Is that the olfactory, right? The first one. Which one is the first one? Is it the I one or
the cranial nerve 1 is the olfactory.
One is olfactory.
2, yeah. The cranial 2, I think it's on the next page.
We can look at it. We can look at it.
Cranial 1, olfactory. Optic is the 2. And then oculomotor is the third. Is the third nerve. Cranial nerve 3. And then cranial nerve 4 is the trochlea.
Correct.
I know the trigeminal 5 and it has 3 branches, 3 divisions, V1, V2, V3.
Correct.
Then we have the abducens, which is cranial nerve 6. Then the facial is 7. Then the vestibulocochlear is 8. The glossopharyngeal 9. Vagus is 10. Accessory is 11, and then hypoglossal is 12. Usually you will hear vagus, hypoglossal, facial, oculomotor, and then maybe once in a while, trigeminal.
Trigeminal is important.
And then once in a while, abducens and trochlea, and accessory.
Right. Okay. So knowing their names is important first to get your question correct. And now, after knowing the names, we have to know how they are arranged in the brain stem, like on the brain. When you take it this way, those that are coming from the brain stem, midbrain, you have to know which is coming from the midbrain, which is coming from the brain stem, or which is coming from maybe the pons and the midbrain area. And then those from the medulla, you have to know that. Well, I'll make them simple for you so that okay. So at least we know that the first 2 are from the CNS, right? They are the CNS, the rest are PNS. Is that correct? These 2 are CNS. Okay, CNS.
Then 1 and 2.
Yes. And then
olfactory and optic.
Yes. So we know where they are coming from already. We don't have to worry so much about them. And where we worry about the cranial nerve 1 is when we are looking at the like how the visual impulse travels to the brain and come back and all that. We can look at that in a different. I think it's in a different section, right? I saw that.
Yes, the ophthalmology.
We'll look at that. Like pupillary light reflex. I think that's a topic. Pupillary light reflex. We'll look at that, where we'll talk about the internuclear ophthalmoplegia and all that. We'll look at that. So let's reserve that. Let's reserve that for now. And also, we also have to know that the second one, which is the optic. Oh, it's the optic I was talking about first. So I mean,
the first one is olfactory bulb.
Olfactory. So the first one,
something to do with smell.
Smell, is just coming from under the inferior surface of the frontal lobe, right? From the inferior, it's lying at the inferior surface of the frontal lobe. So just like we have our nose, inferior to our brain, the frontal lobe is lying right there, and then over there you will find some hair cells that are coming from it. Like they are tiny hair cells, and then they go through this. Let me see if I'll see the skull. I want to see if I'll see the skull.
The foraminus?
The foraminus, yes. It's far back.
The next page.
Yes, it's here.
So you next page.
Correct. So you will find it lying over here in the foraminus, and all those hair cells will come through here and go and line the upper part of the nose, right? Of the nose, and where they can perceive the smell, and yeah, and then they'll send it to the brain directly. Yeah, and here is the cribriform plate. This hole under the skull here is called a cribriform plate. Yeah, as it's here. Yeah. So there's not too much about it, right? The rest of them is what the emphasis is mostly on. That we should lay more emphasis on them. So let's see how we can identify them, because in some diagrams, in some questions, especially NBME love it, they will give you this image, right? And then they'll tell you, describe the patient's symptom to you, and they'll tell you, they'll label them A, B, C, D, which of the following nerves is affected, right? And in the question, you will be able to tell that, oh, this is a cranial nerve 5 problem, right? But how do you point out cranial nerve 5 in this image? It makes sense, right?
Mm-hmm.
Yeah. So now, what you want to know is that starting from cranial nerve 3, which are the PNS, 3 and 4 are from the midbrain. Okay, cranial nerve 3 and 4 are from the midbrain. And if you look here, you can see cranial nerve 3 here. This is it. And the midbrain is here. We don't see it directly, but it is sitting up the pons, because you move from the midbrain, you come to the pons, they come to the medulla. It makes sense, right? This is the pons.
Okay. I'm seeing 3 and I'm seeing 4. 4 is
yeah.
3, 4. Okay.
All right. So you've seen 3, right? This is 4. 3.
3 is very clear.
It's very clear, right? So what you want to do is that it is from the midbrain.
Okay.
Remember, it's from the midbrain. So if I were you, what I'm going to do is that I would list them this way: just midbrain, pons, and medulla, right? So from the midbrain, we have the cranial nerve 3 and 4. They come from the midbrain. So we can see the cranial nerve 3 here, and we can also see 4. So you can see they are all sitting on top of the pons. If you look clearly at the image, this is the pons. Do you see it?
Mm-hmm.
They are coming from above the pons, but because of the way the image is, we cannot really see it well, right? So they are coming from midbrain. Yeah. Now, there are 4 others that come from the pons. 4 other nerves. So 4 here. And also we have another 4 nerves that come from the medulla area. So in all, how many do we have? If there are 12, we have 2 already.
12.
We have only 10 left, right? Because we have 2 from the cerebral cortex already.
So two, so we have 8 left.
Yeah. So 2 from the cerebral cortex, 2 from the
2 from the
midbrain,
midbrain.
and 4 from the pons, 4 from the medulla.
Okay.
It makes sense, right? Pons.
So equal 4, 4.
Yes.
2, 2, 4, 4.
2, 2, 4, 4. 2, 2, 4, 4. Yeah. So I, for some reason, like I just recite midbrain pons medulla. That's the arrangement. Midbrain pons medulla. Midbrain pons medulla.
Okay.
So midbrain is here. From the cerebral cortex, come to midbrain pons medulla. Midbrain pons medulla. Right. That is the brain stem. The brain stem is the midbrain pons medulla. Right. The brain stem. Because the cerebral cortex is sitting on the brain stem. It's like the head is sitting on the neck. Same way. So
Okay.
the midbrain pons medulla are the brain stem. Now, 2 from the midbrain, which is 3 and 4. Now let's look at the pons also. If you know this, then it means that if you are able to exclude these 2, which are so obvious, if you're able to exclude them, right? You can always exclude them, right? And mostly they will not bring them in the question. Mostly it's good. They're just going to lift the brain stem alone for you. So they will not bring these 2 in it. Right. So if they bring only the brain stem, all that you are going to see is the first 2 are from the midbrain. So 3 and 4. And how do you know which one is 3? How do you know which one is 4? Always start counting from the middle. It makes sense? Always move from middle and count outwards. So 3 will be the middlemost one, then 4 comes out next. Does it make sense? Now let's go to the pons. Pons. If 4 are coming from the pons, therefore we'll have kind of 5, right? 6, 7, 8. Does it make sense?
Okay.
Right, because we have 3 and 4 from here. Therefore, the next 4 will be kind of 5, 6, 7, 8. Also, we want to start counting from middle outwards, right? Middle outwards. So if I'm going to wipe this off, middle outwards, how do we count? Which one would this one be? From middle, right? Outwards, from middle outwards. So which one do you think will be this one? Even if I cover the thing. Hello?
That should be 6.
This should be 6. Oh, I missed one. I'm sorry. I mixed one, right? I mixed this one.
The 5 is very obvious because it has 3 arms.
Exactly.
And it's big.
It's the biggest. Yes.
And it's big.
It's the biggest. But you see that this 5, it is coming from the pons, but it's more superior. It's more superior, right? Because if you look, the junction of the midbrain and then the pons, that is where the 5 is coming from. But 6, 7, 8 are coming from the junction of the pons and medulla. Right.
Yeah. So that's 7, 8, and 9.
Yes. So 6
from medial to lateral.
Exactly, from mid. Oh, that's the word I should have.
6, 7, and 8.
6 here, right? This one, 6, 6, 7, 8. If we are right.
And 8.
Yes. Like that. So we finish with the midbrain. The pontine ones. 6, 7, 8. They are out. So now what we are left is, then we come to 9, 10, 11, 12. So they also will come to the middle again and start counting. So from here, you'll find the next one will be 9. Yeah, it's here. It's hiding somewhere here. 9 here is very small.
Very small.
Yeah. Then the next one will be 10, which is also bigger. This one here.
It's bigger.
Yeah. Then you come down 11. 11 is.
That 11 is really small.
Yeah. But look, it's also long, right? Because spinal accessory. So it's also long before the 12 also comes. Yeah. So if you go orderly, you will get it correct. Like if you go, know that, okay, we have first two, but I will send you an image so that we can look at that image also, what the boards would use. They will not
Okay.
be this colorful image. Brain, stem. Quickly, let's look at if we can find an image. But they will give you a CT scan. Oh, let me see. Brain and nerves. Good.
You found it?
I found an image, even though it is labeled, but I'll give another one that is not labeled so that it's better.
So I can use that to practice.
Yes. Okay. Sending. All right. I have sent it, but let me see if I will locate it on here so that I bring it over here. Then we all look at it from the screen so that you see that it's even clearer than what we are doing in the book. Where is it? Okay, where is it? Open with. No, what can open it? Let me see if this can open it. Awesome. Awesome. So now let me share. Let me see, share screen. Awesome. Okay.
Yeah.
Good. Do you see it? Do you see my screen?
Yeah. This is superb.
You see this image, right? This. All right. Okay. So if you see it now, we are able to tell. Right. Something is. All right. Good. Okay. So. All right. So at least we can see this one, right? It's just sitting at the base
The
of
one and two is very clear.
Exactly.
Yeah.
Very clear.
Then the two is next to it.
We'll never ask you about it because it's so clear. All right. So now, based on the method that we used, where would crayon F3 be? Which number here will be crayon F3?
Crayon F3 should be this one.
Which one?
This one.
Oh, you have to tell me. Tell me so that I point it out.
Crayon F3 is below these two round circles.
No,
coming out from the pointer.
so they have labeled them in numbers. So you tell me which number.
Okay, I'm saying number 10. Number 10.
All right. I agree with you. That's crayon F3. Now, which one will be crayon F4?
The crayon F4
Because we said we have midbrain, right? Pons and medulla. Is that correct? First, 3 and 4 are from the midbrain. We start from medial and go outwards, right? The pons also has the next 4, which is 5, 6, 7, 8. We start from medial and go outwards. Medulla also has 9, 10, 11, 12. Is that correct? We start from medial and go outward. So let's apply this method. You need to apply this method several times in order to remember this and pick your
Okay.
answer
Number
fast.
2 will be 4.
Exactly. Number 2 will be 4.
Number 2 will be 4.
Exactly.
And then the bundle will be 5.
Exactly. Which is this one, right?
Yes, the bundle, because it's
good. So,
and then if you're looking medial will be the medial will be 6.
which one? Number what?
No, number 3 will be 6. Followed by number 12.
Which is what?
7. Then the number 4 will be 8.
Okay. All right. I agree with you totally.
Then we now move to the brain stem.
Go to the brain stem.
It's really clear here, but I'll try. It said from top to bottom will be 9.
Nine, which number?
13.
Okay. Okay, so like 9. Go ahead. Which one will be number 10?
Number 10 will be 5.
Okay, I agree with you. Right. Then, of course, this is what?
That's the last one. That is
It's not 12.
No. Accessory spinal.
Accessory, yeah. Spinal sensory, yeah. So that'll be 11. And the 12 will be this one. Yeah.
Yes.
Yes. Another thing
Wow.
that now you get it right. It's not as complex as you thought, right?
Yeah, but looking at this, unless I put a magnifying glass, you can easily miss it.
You can't see it well?
No, not your own, not the one in the book, the one we're using before.
Oh, okay,
Before you
okay.
brought this picture up.
Okay. Yeah. Okay. Sorry. Yeah. I think what they'll give you in the exam will be almost big like this, but just that it will be darker than this. It will not be so clear, to be darker than this.
Yeah, but because this one separates all the nerves, you can see the spinal accessory. But when you look at this one, it's like one is coming on top of the other, because one can easily mistake the spinal accessory.
Yeah, the way it is.
Yeah.
Yeah, the way it is. But you have to remember just that it is like spinal accessory. It's kind of like joining is, I don't know.
Several nerves from together to form one.
Yes, kind of like a confluence. Yeah.
Okay.
And it's for neck movement. It helps move the neck left and right and all that. So another thing that we have to include here is that if the nerve is divisible by, you see how these things, we have I was saying move medial, like medial this way to lateral, right? if the nerve is divisible by 3, sorry, if it's divisible, no, if the nerve can go into 12 for you to have a whole number, like 12 divided by 3, you get 4, right? 12 divided by 4, you get 3, right? You get whole number, you don't get fraction. 12 divided by 6, you get 2, you don't get a fraction.
2.
12 divided by 12, you get 1, you don't get a fraction. Is that correct?
12 divided by 2, you get 6.
Yeah. So if the nerve, 12 divided by 2 is also 6. So if the nerve is divisible by, no, I don't know say, but if the nerve can divide 12 for you to get a whole number and not a fraction, that nerve will be medial. Does it make sense? Because we want to know these nerves, we are not looking at the nerve itself, we want to know where the nucleus of the nerve is originating from.
Coming from, okay.
Nucleus, where is it starting from, which we don't see here. It's within. So the nuclei of these nerves are coming from the middle part of the brainstem, right? So all these nerves, so like grand nerve 3 and 4, they are from the middle of the midbrain. Grand nerve, the next one will be from here. It's only 6, right? From the pons area, it's only 6 that is can divide 12. So only 6 will be from the middle of the pons. Does it make sense? Even though you are seeing the 6, just okay, it's even here, right? It's even here. So even though we see lateral, but we assume that it's coming from the middle of the pons. Right, there's a 6, so we are still correct. And now the next one will be 12 again, right? 12. Grand nerve 12 from here, which is this one. It's also coming from the middle. So all these ones are coming from the middle of the pons. The rest are from the lateral of the brain.
Okay.
Does it make sense?
Okay. Yeah.
Another thing that you want to know is that anyone that is coming from the middle, as we have said, is the function is motor in nature. All those that are coming from lateral are sensory in nature.
Okay. Lateral sensory.
Yes.
Media motor.
M for motor, M for media. Is that correct?
Okay.
Yeah. So if they present the symptom of the patient to you and they tell you, you think that this patient's symptom is a motor symptom, movement problem, right? It's not like weakness. Weakness is sensory. It's not like we'll see some sensory problems later, but it's not more like a sensory. If it's not sensory and it's motor, then the nerve is most likely going to be in the middle, and it's going to be either divisible by 12 to give us a fraction. So it's either going to be 3 and 4, 6, or 12. Does it make sense? Because sometimes when they give you the symptom, it will be difficult for you to know, is this a midbrain problem? Is it a pontine problem? Is it a medulla problem? So if you're able to at least know that this is a motor problem, you can eliminate all that are from the lateral already. Then you narrow down to the medial. Then plus other symptoms, then you can tell that this is a pontine problem. This is a cranial nerve 5 problem. So this is a cranial nerve 6 problem. Because if you know the function of cranial nerve 6, you can tell, right? Cranial nerve 6, we said it was, which one was it? Cranial nerve 6. The abducens?
Abducens.
Good. And of course, you know that if you look at it's for eye movement, right? If you remember that mnemonic that says
superior SO4.
That mnemonic, yeah. LR6, right?
SO4.
Then rest 3. So once the patient start presenting with lateral rectus problem, you know that lateral rectus, what does it do? It moves the eye laterally. So if the person cannot move the eye to that side, then you know this is where the problem is coming from. You'll be able to tell, right? So we'll look at other symptoms that will present later, but this just to know like how to identify which cranial nerve, because they ask about it. Okay.
The origin and where they emerge from.
Yes. Yeah. Mhm.
Okay.
Awesome. All right. So now let's go back to the other slide. Our time is 1 o'clock a little bit exactly.
Yeah. Yeah. I think the only maybe we can do this last one and
Yeah. What is the other slide? Looking for the other slide.
well, no, there's still more. But maybe we can stop from there today. 3 hours. Yeah.
I'm
I was
trying.
going to look for ask for a timetable,
Mm-hmm.
like
I'm trying.
like
Give me a minute. Let me find this. Okay, there's it. I think this is the page we were on. All right. Okay, go ahead.
no, I was going to say about like like they say plan or all these things that you not really plan, the dedicated study plan or how to study, do you have any?
Yeah, there's like a schedule for you. Yeah, we can talk about that.
Mm,
But if we finish this, I'll have to, because
okay.
we are recording, I'll have to stop it so that it doesn't come in the
Okay.
recording. So at least we've seen this, right? We've done a lot for today.
Yeah.
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 Yeah, we've done a lot for today. And do you want to stop here or you want to do a little bit more?
No, let's stop here.
A lot of information, I know.
A lot of information because I have to go over it again. It's
Yeah,
beneficial for me to sit down and go it over again and make
yes,
sure I consolidate so
yes.
that I don't come back and be looking. If you want to go over that one because
Yeah,
it
it's the
looks as
same
if
thing that
it's
we're talking about. It's same thing that we're talking
yeah.
about.
So
The nuclei, I told you they were deeply embedded in the brain stem, right? So I told you midbrain, we have two nerves coming from there, right? 3 and 4, right?
yeah,
Pons, medulla. So the next four are from the pons, the next
1, 2,
four,
3, 4. Yeah.
right? Right. The spinal cord, the nucleus of cranial nerve 11. I mean, it's long, cranial nerve 11, right? It's long. So
The spinal accessory. Okay.
yeah, but still, some books added to the medulla. This is the first time I'm seeing that they added to the spinal cord. First time.
Spinal cord.
It's not a
And it's the
cranial nerve.
only one.
Say that again.
And it's the only one on the spinal cord.
Right. But then why do they call it cranial nerve, you know? But I don't know. Yeah, and then also we said what when it's coming from lateral, these are all new information in your book. When it's lateral, it's for sensory. The function is sensory in nature, and when it's medial, from the middle, and the function is motor. And we said the middle ones
Motor.
are
Okay. Yeah.
3, 4, 6, and 12, right? You remember?
Yeah.
Yeah, 3, 4, 6, and 12. They are the motor in nature, and the rest are sensory. Yeah. Mhm.
So we're taking care of those ones.
Yeah, we have taken care of it. And this is not too like high yield, this one, but they just want you to know like because some of the nuclei are coming from, it's like it's a complex, a nucleus complex. So like nucleus, the solitary nucleus, it has all these cranial nerves are coming from it. Combination is one big nucleus, and all of them are coming from different parts of it, right? The nucleus ambiguous also same, and the dorsal motor nucleus. I think dorsal motor nucleus, cranial nerve 10. Yeah. So we can end here, and the next time this is also important to know. Where is it? Where are you? This one. So the next time is there. Have I moved too fast? Yeah, here. We'll start from here next time.
Okay.
Yeah. Here also you have to also know. Because UWorld, you need to be getting your questions on UWorld and be confident to do well. Right. And I'm giving
So this now, I study this again, then I do some UWorld questions on it.
Yes. If you do this, even if I can start doing, if you review this that we've done, you should be getting UWorld questions correct. If we do the next one, you should be getting most of your questions correct. Because we are almost done with the book. Next, we finish, we are going to the stroke syndromes. No, we'll do the brain, the spinal cord, and then we go to stroke syndromes. Then we are almost done with neuro. Right? So that'll be neuro. Then as for the demyelinating conditions, I'll have a way I'll show you so that you can get them correct. So we'll be done with neuro. And this also I have a way to remember it. Yeah. So I'll tell you later when we meet, okay?
Okay. So now we're not sure of how many hours we're going to stay because so that I know how to plan my payment.
Yeah. No, so that let me stop this. Stop sharing one
Okay.
and stop recording. Where is it?